Hello, everyone. Welcome to the second part of your respiratory lecture. In this lecture, we will cover the following objectives. In this lecture, we're going to talk about respiratory disorders and pathologies. Now, there are a lot of different respiratory disorders that cause difficulty breathing, which is dyspnea. So you can have respiratory distress syndrome, pneumothorax, common cold, COVID-19, the flu, bronchitis, pneumonia, TB, asthma. So there are a lot of these, and they all cause a common problem amongst other problems, and that is dyspnea. That's difficulty breathing. As you remember in the previous PowerPoint, we talked about the upper respiratory tract and the lower respiratory tract. So upper respiratory tract disorders include infections with the upper respiratory system. And these are called, when we get an infection like that, it's called an upper respiratory tract infection or upper respiratory infection, commonly abbreviated as URI. Right? And this is an infection of the mucous membranes of the nose, sinuses, pharynx, larynx, and upper trachea, all of which are a part of your upper respiratory system. It's one of the most common causes of illness amongst people is usually the URIs, and they can be viral or bacterial. But viral is the most common cause of upper respiratory tract infections. The four types that we're going to talk about in this lecture are rhinitis, rhinosinusitis, pharyngitis, and laryngitis. So rhinitis, what is rhinitis? It's basically the inflammation of the nasal mucosa. So your mucosa in the sinuses. It can also affect the eyes, throat, and ears. It can be viral or bacterial. Now, if you have acute rhinitis, then it'll be from 1 to 3 weeks, or if it's chronic, then it can be up to 12 weeks or longer. Now, there are two different types. One is allergic rhinitis and one is non-allergic rhinitis. Allergic rhinitis is when, a person gets, rhinitis, inflammation of the nasal mucosa. Rhinitis means nose, so nasal mucosa is when they get exposed to allergens. So these are people who have allergies to maybe like pollen or environmental allergies or, something like that. And what happens is that their mucosa becomes inflamed, congested, and edematous. It can also be caused by mechanical obstruction within the nose or sinuses. It can also be seasonal. It can be seasonal or it can last throughout the year. Common allergens include environmental, medications, foods, occupational hazards that people are exposed to at their workplaces. And how do we manage allergic rhinitis? The most important way to manage it is to encourage people to avoid exposure to these allergens. Other ways are, we do allergy testing, offer them a desensitizing regimen. They're referred to an EENT, that's eyes, ears, nose, and throat specialists. But the most easy way, the most common thing is to encourage them to avoid exposure to allergens. The medications that are used to treat rhinitis are antihistamines and corticosteroids. Now, the reason why is because when a person gets exposed to an allergen, their body releases, histamines, and so an antihistamine would help, keep that under control. Then corticosteroids are used for inflammation. So when you reduce the inflammation, it makes it easier for the person to breathe. Non-allergic rhinitis is the other type. Now, this is different from allergic rhinitis, right? It does not involve the immune system. Examples are like common cold. So it's not because you got exposed to an allergen. It's basically the common cold, or for example, the flu, COVID-19. They're mostly viral and they spread from person to person through droplets. And how does this happen? Through sneezing, coughing, or just direct contact. Now, this can also be acute or chronic as well. So clinical manifestations, what do we see? What signs and symptoms do we see? We see rhinorrhea, excessive nasal drainage. Remember, the rhino means the nose, right? Rhinorrhea is nasal discharge. If it's bacterial, then it can be purulent discharge. Then we have nasal congestion, sneezing, coughing. Pruritus is like itching of the nose, roof of the mouth, throat, eyes, ears. Everything feels itchy, and that's called pruritus. Pruritus means itching. Low-grade fever. A person can also have a low-grade fever. Chronic rhinitis, the difference that happens with chronic rhinitis is the nasal discharge in chronic rhinitis is discolored. We don't have clear secretions. Normally in acute rhinitis, the secretions are always clear. It's like when a person has allergies, right? Allergic rhinitis, secretions are clear. And bacterial, if it's a bacterial reason for it, then obviously it's going to be purulent. But with chronic rhinitis, it's usually just discolored nasal discharge. It's not clear. Medically, it's a virus, and so it's managed through anti-inflammatory, antihistamines, decongestants, expectorants, corticosteroids. If it's bacterial, the reason for it is a bacteria, and it's a bacterial infection, then the person might get antibiotics. Now, nursing management of rhinitis. What do? You monitor for signs and symptoms. You get a complete history of their symptoms, any seasonal allergies that they have, any environmental exposures. Get their vital signs. See if they have a fever. See if they have an increased respiratory rate or heart rate. Check their oxygen saturation. Another thing that we can do is use a peak flow meter and a spirometry, which can, indicate the severity of the exacerbation or response to therapy. Nasal drainage. Notice the nasal drainage, or ask the patient, is it thin and clear, or is it yellow and green, because then it can indicate an infection. Is it discolored? Find out how long they have been having the problem. And then we prioritize, right? We have alteration diagnosis, nursing diagnosis we can use are alterations in comfort, right? Knowledge deficit. They don't, they need more information about the respiratory disorder. Risk for infection. So if they don't already have an infection, they're still at a risk for infection. So what actions can we take as nurses? We administer any prescribed medications, whether they're oral, nasal antihistamines, corticosteroids, any decongestants, antibiotics if they have infection. Then we can give them like antipyretics if they have a fever, or antibiotics if it's an infection. And we want to always do a lot of teaching when it comes to rhinitis, because remember, especially if it's viral and not allergies, then we need to help break that chain of infection and teach them, the appropriate use of medications. Hand hygiene, avoid known allergens or triggers, prevent the spread of it by, it's important hand hygiene, covering the mouth when they cough or sneeze. We usually say use the elbow, to cough or, sneeze in, and dispose of facial tissues containing nasal drainage. Don't just leave it on, tables and stuff like that. And so we need to spend a lot of time educating our patients to help, prevent infection. Then how do we know that the patient is doing fine? They have a relief of symptoms. They have a decrease in nasal congestion, discharge, and they have a relief of a headache, because sometimes, these colds and allergic rhinitis can cause headaches. Now let's talk about rhinosinusitis. Rhinosinusitis is inflammation of the nasal and paranasal cavities. This includes the maxillary, frontal, sphenoid, and ethmoid sinuses. Now it includes the nose and the sinuses. The inflammation causes vasodilation and increased blood flow to the vascular, increased vascular permeability, which, and then we have the reducing the size of the nasal passage. Now, if you reduce the size of the nasal passage because of the inflammation, then the patient is going to have difficulty breathing through their nose. So what are the different types? You have acute, which is less than 4 weeks, which can be viral rhinosinusitis, which is the most common. It's commonly caused by the spread of URIs to the paranasal sinus. For example, if the person has rhinitis and it's not taken care of, and then it can spread to their sinuses and become rhinosinusitis, which can then also lead to a bacterial infection. Then you have acute bacterial rhinosinusitis, which is ARBS, acute bacterial rhinosinusitis, caused by viral rhinosinusitis trauma or obstruction of the polyps. Then you have, it interferes again with the, nasal passages. And common bacterial infections include Streptococcus pneumonia, Haemophilus influenza, and we have other ones that are I'm sorry, these are so difficult to pronounce. Then we have Staphylococcus aureus. So it can be any, a variety of different pathogens that cause bacteria that can cause the bacterial rhinosinusitis. And for subacute, which is acute is less than 4 weeks, subacute is 4 to 12 weeks, and chronic rhinosinusitis usually lasts greater than 12 weeks. This is caused by acute rhinosinusitis. It's very common in females, basically, most of the time, sorry. What are the signs and symptoms of acute rhinosinusitis? There are 3 main symptoms, which is purulent nasal discharge, facial pain, pressure, and fullness, and nasal obstruction. Now, these are the 3 main ones. This is what differentiates it from normal rhinitis. The other symptoms can include yellow-green cloudy secretions, fatigue, fever, maxillary dental pain, cough, or ear fullness and pressure, symptoms that last greater than 10 days, and then a new onset of headache after 5 to 6 days. And then we have elevated temperature. This is usually in the bacterial ones. So with acute bacterial rhinosinusitis, you have all the above symptoms that we listed, plus the symptoms of upper respiratory infections. What is the medical management for this? We usually do normal saline irrigations to help clear out the nasal passages. Then we avoid antibiotic use for non-bacterial illnesses. So if it's not bacterial infections, then patients are normally not given antibiotics for it. And then if it's bacterial, and it's prescribed if the symptoms last greater than 7 days. So basically, if the symptoms for the rhinosinusitis last greater than 7 days, patients are given antimicrobials. Now, medications that are used for acute bacterial rhinosinusitis, first-line therapy is amoxicillin clavinet. If they have a penicillin allergy, then you'll see doxycycline, respiratory fluoroquinolines, levofloxacin. If the patient fails to respond in 48 to 72 hours and they have persistent symptoms, then the second line of treatment are the second or third generation cephalosporins. And antipyretics for fever, you have analgesics for any pain, and intranasal corticosteroids to help reduce inflammation of the nasal passages, then decongestants and antihistamines. What are some complications that can happen? Now, if we don't treat these infections, especially if it's a bacterial infection, and for example, the patient doesn't take the complete course or they don't take antibiotics at all, and there are a lot of complications that can happen from this. You can develop orbital cellulitis, right? Cellulitis in your orbital area, your eye area. You can develop orbital abscesses, osteomyelitis in the bones of the face. You can also develop meningitis, and then sepsis and brain abscess and bony erosions. So these are some severe complications that can happen from rhinosinusitis when it's not properly taken care of. Nursing management of rhinosinusitis is the same thing as rhinitis. You monitor for signs and symptoms. You get their vital signs. You get the complete history. When did it start? Notice if they have the 3 major symptoms that differentiate it from rhinitis. Notice for any facial pressure, a sense of fullness when we palpate their sinuses. sinuses should never be painful when they're palpated. If they're painful, palpate it to see the area where it's painful. See if they have any purulent, yellow-green discharge coming out, and if there's any swelling, redness, and pain around the eyes, this can actually indicate abscesses or cellulitis, orbital cellulitis, right? Then palpate the sinuses. It identifies presence of fluid within the sinus cavity, which is indicated when, which you can, in what do you call, palpate the sinuses and find out. Sorry. What are the different diagnoses, nursing diagnoses? And our priority is going to be, infection, risk for infection if they don't already have one. Acute pain, because they're going to be it's going to be very painful for them and they're going to have difficulty breathing. So the actions that we're going to take is obviously administer the medications that are prescribed for them. Then once again, we teach them to report to the provider any temperature, increase in pain, change in the level of consciousness, redness or edema around the face or the eyes. It's very important that we teach the patient this. Then we need to also, teach them how to correctly take the medication, especially if they're nasal medications. We need to teach them and let them demonstrate it. So, we know for sure that they know how to use it. And we need to also teach them to limit the use of decongestants and nasal sprays to less than 4 days to avoid rebound congestion. So other stuff that we need to teach them is the proper use of normal saline nasal rinses. And if you notice down here is the technique of using those nasal normal saline rinses. How do we know that the patient, our actions, and our nursing management has worked? We see resolution of symptoms and we see medication adherence in patients. The next thing we're going to talk about is pharyngitis. This is inflammation of the pharynx, also known as the sore throat. As you can see here, it's very sore and red, right? And acute pharyngitis is painful inflammation of the pharynx area right here is painful and red and inflamed. Symptoms are pain, vasodilation, and edema. How do we manage it? We provide symptomatic and supportive measures. We help relieve symptoms, basically. So if it's bacterial, that's for viral, and viral pharyngitis is the most common pharyngitis out there. Then we have bacterial pharyngitis, which is caused by group A streptococcus. You have basically called strep throat, right? Then complications can be severe and life-threatening if it's not taken care of, especially in the sinus, the ear, tonsil, jaw, neck, meninges, infections. So all of these can get infected and it can be very deadly. Then the symptoms that we'll see for bacterial pharyngitis include pain, fever, vasodilation causing all the redness, erythema, and the edema, tissue damage. You sometimes see this white exudate on their pharyngeal area. And then we have halitosis. That is, bad breath. That's the medical name for bad breath. How do we manage it? This is managed by antimicrobials, antibiotics, and analgesics for pain. So the chronic pharyngitis, we talked about acute and bacterial. Now that's for acute pharyngitis that can be caused by viral or bacterial. Chronic pharyngitis is hypertrophic, general thickening and congestion of the mucous membranes. It can be atrophic, which is the late stage of hypertrophic, which you'll see thin whitish membranes. Chronic granular, they're different. That's another type. This is numerous swollen lymph follicles on the pharyngeal wall. This is managed through avoiding irritants that are causing the pharyngitis and managing symptoms. Then we're going to talk about the nursing management for pharyngitis. How do we manage pharyngitis? Once again, we assess for any signs and symptoms of pharyngitis. We check for vital signs, temperature elevations. We do a physical examination. We look inside their mouth, their nose, their face, assess the throat. Ask the patient to say ah and look inside the throat and see if it looks red, inflamed, or it has white patches on it. Check the patient's airway and hydration status. Look for any signs of, toxicity, epiglottis, or abscesses. Look inside their mouth. Just do a thorough physical exam. Ask them about their symptoms. How long did their symptoms last? What kind of drainage do they have? Where is their pain? Palpate their sinuses to see if it's painful for them, right? And then the nursing diagnoses and hypotheses that we're going to prioritize in here are impaired verbal communication. That's related to the inflammatory process. So, when a patient has pharyngitis, sometimes it's difficult for them to speak. And so, you want to look for that. You want to look for if they don't already have an infection, there's a risk for infection, risk for aspiration because they can't swallow too well. So actions that you can take are, perform rapid testing to determine the cause. See if they have a strep throat, right? We do the test to see if it's the flu or the strep throat or, the common test that they do in doctors' offices. Then if they have medications prescribed, administer medications, encourage fluids, if they're dehydrated. If they need fungal pharyngitis, then they need to be given the antifungals. If they have pain or fever, you want to give them analgesics and pyretics. They might be ordered, prescribed corticosteroids to help with the inflammation. Administer the corticosteroids. We're going to teach them to gargle with warm salt water to soothe the throat. It really helps to soothe the throat. They can use anesthetic lozenges or gargles. We get that, the ready-made sprays that they can spray inside their mouth. That also is like an anesthetic lozenge that helps them to, helps relieve the pain and the soreness. They can encourage them to eat soft, bland foods like soups or stews and oatmeal. This can avoid, damaging the tissue in their throat or feeling painful. We want to encourage nutrition because we don't want them to not eat because they're in pain. Avoid, tell them to avoid sharing their food and drinks and utensils with family members and friends because it can spread if it's viral. And teach them hand hygiene. Again, and you'll notice hand hygiene is in almost every single it's related to every single disease process, So teach them to wash their hands often and teach them to cover their mouth when they cough or sneeze. And we always use the elbow, or if they have tissue, use tissue and discard the tissue properly in the wastebasket. How do we know that the patient is feeling, our actions worked is we know that they have relief of symptoms, they have adequate hydration, they have a resolution of infection if they had an infection and they were on antibiotics. So that was pharyngitis. The next one we're going to talk about is laryngitis. Laryngitis is infection of the mucous membranes of the larynx. This is caused by URIs, environmental pollutants. It can even be caused by GERD, gastroesophageal reflux disease. Even use of asthma inhalers can cause laryngitis. Vocal strain from prolonged periods of talking. For example, lawyers and teachers, or people who talk loudly or sing loudly, or it can even be caused by intubation. I remember when I used to teach high school in the past, every week, because I was teaching every single day, by the end of the week, I would completely lose my voice. I had laryngitis. Like, my voice was gone for like hours and hours and hours, and it would take almost a whole day before my voice came back and then back, so it can happen to people who are teachers, lawyers, singers, people like that. And so what are the signs and symptoms? You'll notice hoarseness in their voice, right? And this is related to a recent, upper respiratory infection, aphonia, where they can't speak. Right? Cough, dry and sore throat, difficulty swallowing or eating because there's a lot of inflammation over there. If you notice these pictures over here, these are healthy vocal cords and these are inflamed vocal cords. So there's a lot of inflation there that causes them to have difficulty swallowing. They can also have fever, and it's worse when with exposure to cold. That's why we encourage them to not drink hot or extremely cold liquids, but just room temperature or warm liquids. How is this managed, medically managed? It is the most important, thing the patient can do is voice rest. It's just resting the voice. Don't talk, just rest, stay quiet and rest your voice. That automatically helps them, a lot. Then you have humidified air humidified air, vaporizers, or, then drinking fluids, a lot of fluids. We want to encourage them to continue to drink. Avoid exposure to secondhand smoke. That can, cause a lot of irritation and trigger the inflammation. And if it's bacterial, then make sure they know to complete their, they might be given antibiotics. Then if it lasts greater than 5 days after all the above treatments, then they might need to get, a referral to evaluate for any malignancies, because laryngitis shouldn't last for a long, long, long time. Not greater than 5 days. After greater than 5 days, they need to be evaluated for laryngeal cancer, any malignancy. So the nursing management for laryngitis includes, once again, assessing for signs and symptoms, checking vital signs, getting a thorough, complete history from them, when it started, how it started, all of that. Then you want to also assess their throat, mouth, nose, the entire upper respiratory area. You want to assess for any presence of stridor if they were extubated, or if they were intubated patients and the laryngitis was caused because of the intubation. Check for stridor after, extubation, because this indicates acute obstruction of the airway, and it's a medical emergency that requires re-intubation. That's the reason why when a patient is extubated, they're monitored for all of these things, because sometimes they need to be intubated again. Then prioritizing our hypotheses. What is most important? Remember, we said the top three. What's the most important for our patients is, impaired verbal communication. Provide them with a writing board or something so you can keep that, communication going. Risk for infection. If they're not already infected, then there's that risk for infection. Risk for aspiration related to the inflammatory, the process. What actions do we take? We administer humidification as prescribed. This will help reduce inflammation. Administer antibiotics if it's an infection. Have emergency airway equipment readily available, especially for patients that have laryngitis because of extubation. Always have that available. Monitor for hoarseness and stridor after extubation. Then we want to provide alternatives for communication. We just talked about it. And then we want to teach them also about, medication use, completing all the medications as prescribed. Instruct them on voice rest, and the need to use alternative modes of communication, right? Continued use of the voice will cause strain and delay the resolution of laryngitis. Increase intake of fluids, which helps to soothe the sore throat. If they're smokers, then smoking cessation, we want to encourage them to stop smoking, because smoking can, exacerbate the symptoms. How do we know that everything worked? The patient their voice returns to normal, they're adhering to their medication regimen, they're taking the antibiotics as prescribed, then your teaching has worked, and they have resolution of stridor, especially, if it's related to extubation, ease of breathing, and adequate oxygenation levels. This is how we know that, our nursing management worked. So the next set of disorders that we're going to talk about are lower respiratory disorders. So lower respiratory disorders are disorders of the lower respiratory tract. Now, these can be acute or chronic. They can be inflammatory. For example, examples are atelectasis, aspiration, sarcoidosis. They can also be infectious, such as pneumonia, like COVID pneumonia, tuberculosis, valley fever, lung abscesses. So they can also be, they can either be inflammatory or infectious. The four disorders that we will discuss in Block 1 would be atelectasis, pneumonia, tuberculosis, and valley fever. Atelectasis, what is that? This is a closure or collapse of the alveoli. Now remember, if you remember from the anatomy lecture, the previous PowerPoint, the alveoli is where the gas exchange takes place. So if those collapse, then it's going to directly affect our gas exchange, So the pathophysiology, they can be, acute. It occurs when patients have a stable, monotonous breathing pattern. It can be chronic, occurs in patients who have chronic airway obstructions, for example, COPD, and it can be non-obstructive due to reduced ventilation. Like what was ventilation? Breathing in and out. So if they're not able to breathe in and out, then you can have, the non-obstructive atelectasis. So acute is postoperative pain, sedation, alert level of consciousness, increased abdominal pressure, and fluid or blood in the pleural space can cause, acute atelectasis. Chronic atelectasis is caused by musculoskeletal or neurological disorders. Obstructive atelectasis is caused by blockages that impede the passage of air into and out of the alveoli. And, acute is when they have excess secretions or mucus plugs, impaired, that because they have impaired coughing or, coughing mechanism, they build up these mucus plugs in their alveoli or a foreign body, right, in the, your alveoli. Chronic examples of chronic obstructive atelectasis include COPD and lung cancer. Now, what are the cause dependent? So acute bronchial obstruction is, you have acute, you have compression of the lung tissue, then you have chronic obstruction. What are the signs and symptoms that we see in when a patient has atelectasis? We see dyspnea, of course, difficulty breathing, cough, and sputum production. They're, coughing out sputum. Marked respiratory distress, especially if there's a large amount of lung tissue involved, then you'll see, a lot of respiratory distress. Tachycardia, tachypnea, pleural pain, because now their alveoli are collapsed, and so you have that when your pleura is rubbing against each other, you have that pleural pain every time they breathe in and out. Central cyanosis, basically you see cyanosis, which is, lack of oxygenation. Anxiety, patient might even display anxiety. This is to diagnose atelectasis, a chest x-ray is done, or there is a CT scan that's done, right? And, pulmonary function tests, bronchoscopies, sputum cultures, and all of these can tell us the cause and what's going on. Medical management includes prevention is the biggest one. Frequent position changes in patients. Early mobilization after surgery, deep breathing exercises. That's the reason why after surgery, we encourage our patients to use the incentive spirometer so they can practice their breathing. Then we have administering medications for any pain that they have. Monitor for their respiratory depression. Notice their respiratory rate, their oxygenation, their breathing patterns. See how they're breathing. Look at their chest movement. See if they have any retractions. Retractions are a bad thing. You never want to see retractions, and you'd never want to see use of accessory muscles. For example, for breathing, you need your lungs and your diaphragm and your rib cage. If you see the person using their stomach to breathe, then that's not a good sign, right? We also perform postural drainage, right? Chest physiotherapy, chest percussions, suctioning. We do suctioning to remove any, excessive secretions. So if you notice over here, there's this abbreviation we use. It's called ICOF, and these are the, different things we can teach our patients to do to prevent atelectasis. Incentive spirometer is a huge one. Here's a picture of it. Here is the procedure for an incentive spirometer. Please review this before class. So what is the nursing management for atelectasis? We assess first is get a health history, a thorough health history. Any reports of difficulty breathing, cough, sputum, what kind of sputum it is, what color it is, how much it is, any pleuritic chest pain that they're feeling, right? Physical examination will include assessing respirations, the rate, depth, and effort. the lung sounds, any signs and symptoms of respiratory distress. That includes use of accessory muscles, labored breathing, low oxygen saturation. Check for, the effectiveness of their cough. Cough can be productive or non-productive. Non-productive is when they're coughing, it's not a deep cough and coughing, but they're not, nothing is coming out. There's no sputum coming out. Productive cough is when you actually have sputum come out. If they do have sputum, then notice the color, the consistency. Is there any odor in the sputum? Right? Then the other signs and symptoms would be increased secretions or difficulty in, expectorating them. Like, for example, coughing those secretions up. Right? So, and this can also happen because of the patient's level of mobility, especially after surgery or something like that, or patients who are immobile and they're laying, that's why they develop pneumonia so much, right? Or atelectasis, you want to make sure that they get up and they're mobile. So they can expectorate that sputum. And check their ADL ability. That's important too. And then you inspect their chest symmetry, any deformities, any surgical incision. Palpate for areas of tenderness, and notice any abnormal findings. Diagnosis, what are the different nursing diagnoses and hypotheses that we're going to prioritize in this case? Ineffective airway, impaired gas exchange, activity intolerance, because they have no energy, because they're not getting enough oxygenation. Ineffective breathing patterns, right? They're using the accessory muscles. That's an ineffective breathing pattern. Risk for infection if they don't already have one. Anxiety is not a good sign because that shows hypoxemia and hypoxia, and you don't want to see that in a patient. And some patients can develop anxiety because they're having difficulty breathing, and it's very, they get anxious. And then knowledge deficit, sorry, I didn't mean to write deficient over there. So what are the actions that we can take? Promote airway clearance, promote deep breathing, the incentive spirometer use, postural drainage, monitor effectiveness of the airway patient, see how they're breathing, check their oxygen saturation, right? Optimize respiratory function by frequent repositioning, early ambulation after surgery, administer oxygen if the doctor has prescribed it, consult respiratory therapists, RTs, manage their pain. If they're in pain, then assess their pain level and administer analgesics that are ordered. Use non-pharmacological measures as well. For example, relaxation, distraction, just a little back massage, right? Promote activity tolerance, physical activity as tolerated. Monitor vital signs during their and after their activity. So before they, while they're ambulating, monitor their vital signs, and after they finish ambulating, monitor their vital signs. It will tell you if they have respiratory distress. To facilitate the breathing pattern, deep breathing exercises, once again, pursed lip breathing and relaxation techniques, deep breathing techniques. Keep them in an upright position. The best position to keep a person who has respiratory issues is in a high Fowler's position. Then you want to prevent infection, promote hygiene, encourage vaccines. If they haven't received their vaccines, encourage them to, get their vaccines. Check for signs and symptoms of infection like fever, increased sputum production, changes in the character of the sputum. Address their anxiety if applicable. Educate them about breathing, positioning, mobility, signs of infection, skin care, hygiene, incentive spirometer use. How do we know that the patient all of this worked and the patient is doing better? Is the patient's breathing improves, they maintain appropriate oxygen saturation, they're free of complications. So all of this is the nursing management for atelectasis. The next one we're going to talk about is pneumonia. And this is very common, and pneumonia is the infection of the lung, parenchyma, functional lung tissue, basically. And it results from bacterial, viral, or fungal infections. These are the different classifications: bacterial, viral, fungal, or chemical. Now, what are the different types? You have community-acquired pneumonia. You have methicillin-resistant Staphylococcus aureus, MRSA pneumonia. You have community-acquired pneumonia. You have hospital-acquired pneumonia. You have healthcare-associated pneumonia. And then you have COVID pneumonia. There are different types of pneumonia. Then you have, how is it transmitted? is transmitted through, aspiration, inhalation, hematogenously. So these are all, means of transmission. Who are the high? Some people are at higher risk than other, and these are clients that are debilitated by accumulated lung secretions. Some people just make a lot of lung secretions, and it debilitates them. And these are people who, for example, have asthma, chronic obstructive pulmonary disease, sickle cell anemia. Then you have cigarette smokers who are also at high risk, people who are immobile, who have impaired mobility, immunocompromised people, people who have a depressed gag or cough reflex, people who are sedated, people who are experiencing neuromuscular disorders, people who have nasogastric or orogastric intubation. They are at high risk for pneumonia. Hospitalized patients are also at high risk for pneumonia. People who have altered levels of consciousness, people with brain injury, alcoholics, drug overdose victims, stroke victims, all of these people are at high risk for pneumonia. Clinical manifestations, you have common clinical manifestation. This is abrupt onset of fever or chills, tachypnea, rapid bounding pulse, chills, productive or non-productive cough. They'll complain of pleuritic chest pain when they're breathing, right? They have fatigue. There's just myalgia, like every muscle hurts in their body. Arthralgia, that means all their joints are hurting. And if you listen to their lung sounds, you'll hear crackles. And most of the time, you'll hear the crackles in the lower lungs. Then these on the chest x-ray, you'll notice infiltrates or effusion. Basically, there's fluid in their lungs. They have elevated white blood cell count. Then you know they have an infection, right? And then you do ABGs, which are arterial blood gases. Remember we mentioned a little bit about acid-base balances. You're going to cover this more in block 2. But the ABGs will show hypoxemia. Then they'll have hypoxia. There's sputum cultures that were taken and sent to the lab, which is a standard practice. Normally will come up with offending organisms like bacterial organisms, right? So for older adults, they'll have all the common symptoms of pneumonia, plus they'll have confusion, lethargy, malice, anorexia because they're too tired or have no energy to eat. They'll have a rapid respiratory rate and tachycardia. Pneumonia is treated, dependent, on the type of pneumonia and the patient's condition. In severe cases, the patient is hospitalized, they're given IV antibiotics. But in low severity, where the symptoms aren't very, severe, they're usually sent home with antibiotics. Oxygen therapy is given for hypoxia. We're going to talk about oxygen therapy some more in skills lab. We want to monitor patients with chronic lung diseases, and patients who have COPD, for example, chronic obstructive pulmonary disease, it's not recommended to give them too much oxygen. Adequate hydration. You want to always encourage the patient to drink, like as much fluids as they can, because this helps to reduce the viscosity of the secretions, the very thick secretion, that helps to make them thinner, which will then be easier for them to cough up. Medications that are used are bronchodilators, Combivent, administered via nebulization, the metered dose inhalers, any inhalers, antibiotic therapy based on the organisms, right? And then initially they're given broad spectrum antibiotics. We do a culture, and then after we get their culture and sensitivity results back, then they're prescribed a more specific antibiotic. We also want to encourage prevention of pneumonia in older adults. Make sure, encourage them to get the annual flu vaccine and pneumonia vaccine after the age of 65, especially or even younger if the patient is at high risk. You want to encourage your, immunocompressed or debilitated clients to get the annual flu vaccine and pneumonia vaccine to avoid infections, to maintain, their nutrition, adequate hydration, make sure they get adequate rest. All of these are very important to help them prevent pneumonia. Complications from pneumonia, once they get it, include, more necrotizing bacterial pneumonia, fibrosis of the lung. They can develop acute meningitis, empyema, bacteremia, where the bacteria reaches their blood, atelectasis, collapse of the alveoli, collapse of the lung, septic shock, acute respiratory failure, that's ARF, organ failure, and then you can have agitation and restlessness from the hypoxia. Agitation and restlessness from the hypoxia is a very important sign to notice. It indicates that they have low oxygen saturation levels, especially if the patient wasn't agitated before or restless before, and all of a sudden they're starting to get restless. Nursing management for pneumonia includes, getting, obviously you're going to get a health history, when did it start, all the signs and symptoms, all the subjective data. Then you want to, do a sputum culture. The doctor will more than likely order a sputum culture, but you do want to check the sputum for volume, color, consistency, clarity, any odors, because Pseudomonas pneumonia Pseudomonas is a type of bacteria that will give it a very pungent smell to the sputum. You want to check their lung sounds before and after coughing. You want to assess respirations, the rate, depth, pattern, use of accessory muscles. You want to assess their skin, the nail beds, the mucous membranes. Is their color appropriate for the ethnicity? Or do they look cyanotic? Like, do they have circumoral cyanosis? Like, they have blue, cyanosis around their mouth, or and their skin. Then you want to check their mental status. It's extremely important. Restlessness and irritability. This is an early sign of cerebral hypoxia, which means hypoxia in the brain, right? The brain needs oxygen, and if it's a very serious sign. What are the priorities that we have? What are we going to prioritize for this patient? Our top threes. So we have ineffective peripheral tissue perfusion, because the lungs are what, oxygenate the blood. So if the lungs are not working very well and the person has, a lower tract respiratory disorder, then obviously the gas exchange is not going to happen as it should. And so that affects our perfusion and oxygenation. Ineffective breathing patterns, impaired gas exchange, risk for acute confusion. We don't want to see that acute confusion in patients. So the next thing is our actions. What do we implement? We want to assist the client to cough productively. We can do this by using the incentive spirometer, including, encouraging deep breathing. And then that will help them to cough. Humidified oxygen to loosen those secretions. If they need suctioning, then we give them suctioning. Chest physiotherapy, which helps to break up the mucus and, sputum in their chest. Provide them fluids up to 3 liters a day, unless it's contraindicated. Like, for example, for heart failure patients, they have fluid restrictions. Unless it's contraindicated, we want to encourage up to 3 liters a day of fluids. This helps to thin the secretion and facilitates, expectorant, like coughing up the sputum. Essential, especially if they have fever. The body, when a person has fever, their body loses 300 to 400 milliliters of fluid through their lungs. You want to monitor their arterial blood gases, ABGs. You want to monitor those numbers. You want to monitor their oxygen saturation, their pulse oximeter. It should be greater than 95%. If the doctor has prescribed oxygen, then give them humidified oxygen. Monitor their temperature regularly. You want to provide adequate rest periods, uninterrupted sleep to conserve that energy. Because when your body is sick, it has higher metabolic demands, and it really causes people to feel very fatigued. So you want to give them adequate rest. But you also want to encourage mobility, but then just adequate rest and activity periods. Then decrease metabolic demands, administer antibiotics as prescribed, Teach the at-risk clients about preventions and risks like vaccinations, the pneumonia and flu vaccine. Healthy adults develop, protection in 2 to 3 weeks after taking the vaccine. Now teach the patient about hand hygiene, relaxation, taking antibiotics as prescribed, any signs and symptoms of worsening respiratory status. How do we know that all this works? We have patient with mild infections, it's well managed, hospitalized patients fully recover and discharge without complications. The next thing that we're going to talk about is TB, tuberculosis. What is tuberculosis? It's a significantly potential and potentially life-threatening communicable lung disease. It's caused by the organism Mycobacterium tuberculosis. After initial exposure, the bacteria encapsulates like a tuberculoma and remains dormant until a later time when clinical symptoms appear. Transmission is airborne and droplet. We put the patient on droplet precautions and airborne precautions. They're put in a negative air pressure room, and you need to wear a N95 respiratory respirator. Classifications, you have latent, tuberculosis, primary tuberculosis, drug-resistant, tuberculosis. Then you have primary progressive tuberculosis, which is very small percentage of people are exposed to this bacteria. What are the signs and symptoms? Most of the time TB is asymptomatic because sometimes, a lot of times it's latent, right? You get exposed to it and then it's just dormant in your body, right? So you don't have symptoms. But when symptoms do appear, the most common symptoms are fever with night sweats, big sign, night sweats, right? Anorexia, they lose weight, without even trying, right? Malice and fatigue, cough, hemoptysis, where coughing up blood is a very common sign of TB. Dyspnea, difficulty breathing, pleuritic chest pain on inspiration. So while they're inhaling, they're feeling pleuritic chest pain. Cavitation or calcification of the lungs. That will show on the chest x-ray. Right, then you do a positive, sputum culture. If the sputum culture comes back positive for Mycobacterium tuberculosis, then we know the patient has TB, right? Then they have recurrent upper respiratory infections. This is also a sign of TB. So medical management includes lab testing. We do a sputum test and culture for acid-fast staining. It's the type of a culture that's done. Skin test. We do the Mantox, tuberculin skin test. It's a standard method for determining the infection. But then the results are read. It's done. It's an intradermal injection. We inject 0.1 milliliter of the solution, and we read the results in 48 to 72 hours. And it's positive if the area that the injection was given is greater than 5 millimeters or more, right? Or if it's smaller, then it's considered a negative test. Now, if the person has a history of, in some countries, patients are given the BCG vaccine, right, as a prophylactic. So if the patient comes from a country where the BCG vaccines are a common practice, then if you do a skin test, it's going to show positive because obviously, they had that, in immunization, the BCG vaccine. And so it's going to show positive. So in that case, they're evaluated using a chest x-ray to see if there, any calcifications or cavitations in their lungs. So the treatment for TB involves, per the CDC, is to cure the patient and minimize transmission to others, which is extremely important. So the medications used to treat TB is a 4-drug combination, and it's continued for 9 to 12 months. And so the first line of medication includes isoniazid, rifampin, pyrazimide, and ethambutol, right? And then these are combination medications. So the patient basically discharges. They need a lot of education on how to take the medications. They need to understand how transmission is prevented. It's extremely important. Complications, if you notice over here on the side, it explains how the transmission occurs. You know, with TB, please read over this. Complications involve respiratory failure, bronchopleural fluid formation, pleural effusions, meningitis, lymphadenopathy, bone disease, and liver and kidney failure. TB is a very serious thing, and the most important thing we can do is, per the CDC, is to cure the patient with that 4-drug combination for 9 to 12 months and prevent transmission. Extremely important. Nursing management, we assess for signs and symptoms. All the signs and symptoms of TB. Did they have recurrent upper respiratory infections? Did they travel outside the country? That is a huge finding. Most of the time, people who have TB have traveled outside the country in the past few weeks. So we need to know if they've traveled. If they're coughing, do they have a fever? Do they feel night sweats? If they're coughing up blood, if the sputum looks pink or red. You want to check their temperature, is their sputum blood tinged or rusty colored? You want to listen to their lung sounds. You would hear wheezing, rales, and rhonchi. The diagnosis, the priorities for a patient will be ineffective peripheral tissue perfusion, obviously because they're not able to oxygenate their blood, ineffective breathing patterns, impaired gas exchange, and risk for acute confusion, again, because hypoxia does cause confusion, And the actions that we take include collecting sputum cultures as needed. If they're negative, then they can return to work in 3 days. We place the client in respiratory isolation. This is negative air pressure rooms, a private room that is negative air pressure, not just a regular private room. When we enter the room, there are very specific PPE that we have to wear, and especially the most important one is your N95 respirator. Then you have administer anti-TB medications as prescribed, the 4-drug combination we mentioned earlier. Refer the client to high-risk persons to the local health department for testing and prophylactic treatment. Promote nutrition, because remember, they lose a lot of weight with the TB. Provide client education. Tell them to cough into tissues. Dispose immediately in biohazard bags, not just a garbage can. Take all medication as prescribed for the entire time, daily for 9 to 12 months. Skipping that dose, and remember we talked about antibiotics and stuff, and what happens when we skip doses. Skipping doses can lead to a public health hazard, because now they become resistant, and now it spreads and spreads. Teach them to wash their hands and use the proper technique. Tell them to report any symptoms of deteriorating conditions to their provider, especially if they are bleeding, a lot of bleeding when they cough. How do we know that everything worked? There's a successful treatment. Client is following all the prescribed transitional plan of care. Patient to gain and maintain a stable body weight and absent of cough and sputum production. Another thing we need to also remember with TB management is health promotion and disease prevention. We need to, educate clients who live in high-risk areas for TB, and family members of clients who have TB. We need to make sure they don't, get it from their family member. Screening is very important in people born outside the U.S. and migrant workers. Early detection and treatment are vital. TB has a slow onset, and the client might not be aware until the disease is advanced. And then now it can spread even, very fast. The diagnosis should be considered for any client who has a persistent cough, chest pain, weakness, weight loss, anorexia, hemoptysis, difficulty breathing, fever, night sweats, or chills. Individuals who have been exposed to TB but have not developed the disease can have latent TB, and it's extremely important to find out. Transitional care is is a care that we want to provide to the patient when they leave the hospital, because obviously they can't stay at the hospital for 9 to 12 months, right? So when the patient with TB has been stabilized, their fever and chills are gone, their nutrition has been controlled, they're not coughing as much, but they're not coughing up blood, they're not coughing that much, they still have to take those medications for 9 to 12 months. So the treatment continues at home. It's important to train that individual to take all the medications that were prescribed the way they were prescribed, right? And do not skip doses. Do not, just say, okay, I'm feeling better, I don't need this. No, they need to continue to take those. Family members are excluded from this, from this role of taking care of them. The patient has to do it themselves. If family members are taking care of them, they have to follow isolation guidelines. The patient will remain in home isolation, receiving periodic sputum cultures to determine the effectiveness of treatment. So home health care nurses will, get the sputum cultures from them periodically. And the need for home isolation may last up to 6 weeks, depending on the patient's response to therapy, depending on how many symptoms they have, how much resolution was achieved. The last thing we're going to talk about real quick is valley fever, which is common in Arizona because obviously it is caused by fungi, that, is in the dust. So clinical manifestations, those are the different types of valley fever, different high-risk groups, the pathophysiology, of valley fever. And then the high-risk groups, are listed here. Please review that. Clinical manifestations, only 40% of the cases are symptomatic. Symptoms start 1 to 3 weeks after the exposure. You'll see fatigue, cough, dyspnea, headache, night sweats, myalgia, and rash. It sounds a little similar to TB, but again, the diagnosis is made after testing. So that's why it's very important to get all the details from the patient. Medical management is we diagnose it through a serum, blood tests, cultures, and microscopy. There's specific valley fever. Then they're given antifungals like fluconazole or amphotericin B for people who are immunocompromised. They have severe or significantly debilitating illnesses. You have, if the person has diabetes or, other comorbidities, people who are pregnant, people are of African or, Filipino ancestry. These antifungals are usually given because they're at high risk. Well, how do we prevent it? Travelers should limit the exposure to outdoor dust in endemic areas or wear N95 or where they can wear N95 respirators when they go out in dusty areas. For example, when you have dust storms and things like that, unless you really need to be outside, we encourage patients to stay indoor during dust storms. Travelers should, anybody who's traveling to a place where it's very dusty, make sure you wear your N95 respirators, but it's treated with antifungals. Nursing management includes monitoring for signs and symptoms, monitoring vital signs, getting a health history, their travel history, encourage rest, manage pain, and observe for skin rash. This is it for our lecture on respiratory disorders. I will see you all in class.